So welcome everybody to this third episode of our Upstream Lab Speaker Series. My name is Andrew Pinto. I'm a physician and scientist at the University of Toronto. And I just want to begin by acknowledging the land that we're located on here in Toronto. It is the traditional land of the Huron-Wendat, the Seneca, and most recently the Mississaugas of the New Credit. It's home today, of course, to tens of thousands of Indigenous individuals from across Turtle Island. And in addition to being grateful to be here, to work and to exist in this land, it's also a good reminder to think about the calls to action of the Truth and Reconciliation Commission of Canada, particularly those that are specific to those who work in healthcare and to health and in health research. And so I'm here presenting on behalf of the Upstream Lab, which is the team that I direct. We're a diverse team of staff, graduate students, fellows, patient partners, community members, and many, many collaborators. And we do work in 4 areas: tackling the social determinants of health, which is something we're going to be talking about today; population health management, using data science to enable more proactive care, and then also supporting clinical trials. You can find out more about our work at upstreamlab.org, and you can follow our work through our monthly newsletter. So today's topic is really a bit about questioning how we think about addressing the social determinants of health, and maybe being a bit provocative in terms of thinking about, are there downsides to approaching these social issues from a health perspective? Rudolf Virchow, who's a 19th century physician and social reformer, famously said that medicine is a social science and politics is nothing else but medicine on a large scale. But there are really important things we should consider when healthcare entities get involved with these social issues. So joining me today, I'm really, really grateful to have 3 amazing colleagues join. And really look forward to this conversation with them. So first, Dr. Arvin Garg is a professor of pediatrics and vice chair of health equity at the University of Massachusetts Medical School and at UMass Memorial Children's Medical Center. His research has focused on addressing adverse social determinants of health within pediatric care, particularly for low-income families, and his work has informed professional and national guidelines. Dr. Kate Mulligan is the Senior Director of the Canadian Institute for Social Prescribing and an Assistant Professor at Dalla Lana School of Public Health at the University of Toronto. Dr. Mulligan is a health geographer and a policy professional with a really strong interest in how we can advance healthy and equitable communities. Her work has been supported by Toronto Public Health, Ontario's Ministry of Health, Health Canada, and the United Nations. And finally, Dr. Ritika Goel is a close friend and colleague, and she's a family physician at the Department of Family and Community Medicine at the University of Toronto and works at the St. Michael's Hospital Academic Family Health Team. She's been engaged in health-related activism, education, public speaking, and writing that occur at the intersection of health and social justice throughout her career. And after serving in a number of different positions within the University of Toronto and also at the College of Family Physicians of Canada, she's currently serving as the Social Justice, Anti-Oppression, and Advocacy Theme Lead for the MD program and the postgraduate program at the University of Toronto. So we have, really fantastic group of people here to talk about this issue and bring some different perspectives. So I'm going to first start by just inviting each of you to tell us a little bit about your work as it pertains to tackling social determinants, and what brings you to maybe this conversation about, are there maybe some important things we should be concerned about or maybe questioning? And I'll go in kind of reverse order. So I'll start with you.
Sure. Thanks, Andrew. Thanks for hosting this really important conversation. So I envision my work in sort of three different streams. So there's of course the clinical work. So I've been working for the past decade or so, really focusing in on serving marginalized communities, and that has included a number of different communities, including people experiencing homelessness, folks with severe mental illness, and people who use drugs, which are often sort of intersecting together. As well as migrants, including immigrants, refugees, and undocumented folks, many of whom have a lot of barriers, as you know, to accessing healthcare in our healthcare system in Canada. And finally, have also had the privilege of working with a lot of trans and non-binary folks, including youth. Um, Particularly important given a lot of the conversations happening right now in south of the border around supporting that community. So that's sort of the clinical piece. And then I've been engaged in quite a bit of activism over the years, which I find is sort of what grounds me in this work. It sort of keeps me remembering what it is that we're here to do, and being connected to social justice movements and thinking about the role that physicians and health providers should be playing in that type of space. And then finally, particularly more recently, there's been a significant thread of medical education work. So now I serve in this role for the MD program and for the postgraduate program at U of T. And it's been a really nice opportunity to think about how we can bring those learnings from clinical work and from activism and community spaces into our teaching with future physicians and health providers.
That's great. Thanks for that. I'll go to you next, Kate, to just tell us a bit more about your work and maybe a hint of what kind of brings you to this discussion today.
Sure. Thanks, Andrew. So yeah, I mean, I'm the non-clinician in the room today. I'm a health geographer by training, but most of my work really has been in the realm of public policy and healthy public policy writ large. So many people begin their careers at that individual level and start thinking more broadly about policy and systems over time. And I've kind of gone in the opposite direction. So I started out as the researcher for health and social policy for the Ontario NDP, the New Democratic Party at Queen's Park. And that's where I had my grounding in social determinants of health and health equity, and decided to go back and do my PhD after that, after learning about the huge discrepancies in life expectancy and health experiences and health outcomes, radically different across neighborhoods, across population groups, across geographies, here at home and around the world. So I spent years working in public health, working with community health centers, advancing a range of different approaches to really address some of those social and structural determinants of health from a critical lens, but also a pragmatic one. And so now what I'm doing is heading up that Canadian Institute for Social Prescribing, which is meant to be a network and a focal point for people taking a broad range of approaches that try to address social and structural determinants of health. I think all sectors of society have an obligation to act on the evidence, which is that a huge amount of our health and health outcomes are determined by these social and structural factors. So that includes health and healthcare, and that's one important component of the work of social prescribing here in Canada and around the world.
Thanks so much, Kate. And I know we're going to get more into just what social prescribing means and how it relates to also, some of the challenges around language as well, and that we use in this space. And Arvin, do you want to tell us a bit about your journey and the work that you've been doing?
Yeah, thanks everyone for having me. I'm the oddball American on this call here, so I'm glad I went last because we Americans tend to have a tendency to overstep our boundaries. So I'm a general pediatrician. I'm from Boston originally and still am. I live outside the Boston area. I'm a Boston Bruins fan, although both the Maple Leafs and Bruins kind of failed this season in the playoffs, my team more so. But I have been working in this space for about 20 years now. I like to say this has been my fellowship project. My fellowship project really came from my clinical experience where I was precepting residents in Baltimore who were seeing our patients, taking care of the children, and kind of realizing that they were doing a great job, but we're missing the true drivers of children's health and development, really the social circumstances, the social determinants of health. And so that became a research project of mine, and I've kind of been riding that wave for the past 20 years or so. It's been remarkable to see its expansion at least in the healthcare system in the US, which has also given me a lot of pause about the direction it's going into. And so that's why I was really excited to join this conversation that Andrew organized.
Thanks so much, Arvin. And I think what's neat is also you've been part of this discussion over a fairly long period of time, and you've been seeing it evolve too, and also kind of which direction we're going. For me, I think a lot about, I kind of similar to Rithika, I came into clinical work with some experiences in activism and pushing for social change, and that kind of the need for that got reaffirmed through clinical work and through what we see with our patients, what they're struggling with. And then for me, a really seminal thing was actually the World Health Organization report in 2008 on the social determinants of health, the final report of the Commission on Social Determinants. And I think I was really struck by the language that was used of like social injustice is killing people on a massive scale, and the call to action that represented. It wasn't just kind of a dry compilation of facts. It really helped say we're not doing enough, and that we're seeing deepening inequities in societies, even in societies that had so-called universal, health systems, which of course still didn't reach everybody, like with at this point about people who are without health care insurance in countries like Canada. But that to me was kind of a trigger. But then since 2008, where we've seen a lot of energy going into thinking about how do we tackle the social determinants of health within health settings and through health systems, starting to be maybe a bit of an issue too, and maybe we could chart that course a little bit about how do we get to this point of actually engaging with interventions like social prescribing, or some of the work, Arvin, that you've done around screening for social needs and integrating services within health settings. How did that happen? Maybe Kate, do you want to start? How do you see social prescribing, which has arisen? Why did it arise?
I think there are a few key reasons. I think one is this is work that's been going on for millennia, right? Human beings have been taking care of one another and the things that we now call social determinants of health for a really long time. But what hasn't really happened is doing that systematically, doing that in a way where we can evaluate and measure and understand and learn about the impacts of these on people's health experiences, their health outcomes, and their use of health services. And that we can start to really consider the limits to our return on investment in acute care, and think about better ways of organizing health systems where it matters. And from my perspective, the evidence shows that where it matters is at the community scale. And so things like social prescribing are tools that people in a given practice can use toward taking their next step in addressing social determinants in a more systematic way that is better recognized by the general public and by decision makers. It's a lot easier to say the term social prescribing, even though it has its challenges, than to talk about asset-based community development, social determinants of health, some of those concepts that are common sense to people who are well versed in this, but not for everyone. And so an open umbrella term that helps bring us together in the same direction helps us take action on what we know are some really key drivers of health that face huge underinvestment. If we can start using better terms and measuring a little bit better and thinking more clearly about why it matters to do work there, then it helps us to provide the resources to where they're most needed.
That's really neat. And there's several things in that. One is that you see these types of interventions as more a tool that gets things started, and that also, and we'll talk a bit more about language, but that it's something that's maybe more comfortable for health systems and people in healthcare to use this type of language, because other types of language of what we really want to see happen like you mentioned, building assets and communities that wouldn't resonate in the same sort of way.
Yeah, it's part of meeting people where they're at, right? We do that for people in communities, clients, patients, and we need to do that for all participants across the system. That's what knowledge translation and mobilization is all about. So finding enough common ground to start working together. It's certainly not an end point. It's a tool for getting people to take those next steps.
That's really neat. Arvin or Ruthka, like what do you think about that, as these types of embedding these types of interventions is more of a way to get things going or a way to start the work? Ruthka, what do you think?
Yeah, I think, I'm really glad that we're having a conversation that takes a bit of a critical lens, because I think it's complicated, right? Like, we are now living in an era about 50 years into the economic policy of neoliberalism, where we are seeing, social structures and social safety nets have really just not been supported. And living in downtown Toronto, it's very, very clear how you see the polarization now of the income distribution, where it's essentially, I see increasingly the folks that live in the community that we serve downtown are either people who are on disability or on social assistance requiring, public housing, or people who are much more privileged and can afford to live in these spaces. So I think in a way, we have to do everything that we can do at that micro level, making sure that we're kind of getting providers on board, getting their buy-in. But at the same time, I think making sure that we're coupling that with sort of meso level and macro level policies and interventions, which I know everyone here thinks about a lot, is really important, because I do see how it would be sort of more palatable to the powers that be to allow providers and nonprofits, et cetera, to pick up the slack, rather than actually properly investing in our social safety nets, which have been decaying.
Yeah, and I want to touch on that and hear from Arvin about, does the meso and macro follow? Like, so and for everyone, when we say micro, we think about things that we incorporate at the patient or individual level to help that individual with the social need that they're dealing with. And the meso being more at the higher level, like maybe a whole organization or a local community, and the macro being at the policy level. But do they always follow, or have we seen times where we kind of stick in the micro and at that, what can we fit into clinical work, and we don't really take action? Arvin, what have you seen, particularly with your perspective from the US?
Yeah, it's a great question. Also, I'm enjoying the banter in the chat about the sports teams, but the Celtics also ripped my heart out a few weeks ago. But talking about this important topic, in the States, we're still far behind in our social safety net compared to Canada, and for me, I started in the micro level when I did my research and kind of had realized quickly that you can do all the screening you want. You can try to identify all the needs that families will share with us, but the solutions aren't in the healthcare system. They are in social policies, really, and they've been inadequate for generations and generations. A quick example is the child health, the child credit, the child income tax credit, where as part of the stimulus package in the United States, a $1.9 trillion package, we were able, I don't say we, but policymakers were able to add that for every family with a child less than 6 years of age, $3,600 was given to families as a basic income. And for kids, for families with kids 6 and older, it was $3,000. And because of, I'd say, stereotypes about how poor people live and what they want to use their money with, and in the US, there's a lot of racial overtones for that, a lot of racism that's embedded in these conversations. A couple of senators decided not to vote for it again, and overnight, 4 million children entered poverty again because of that social policy. So we can do all the screening we want. We can do all the work to try to connect families to resources, but that capacity is not at the level where it can be. And we're hitting this, like, at least in the US, we're hitting this this conflict between public health, investing in the social safety net, social policies, and the healthcare system. And so as a healthcare system, we're trying to, social determinants of health has now entered the conversations and multiple conversations about what we should be doing and how we should do it. But really, it's all secondary to social policies and to the social safety net. And for us to, we need to move even further upstream in our thinking as healthcare providers to not only try to identify these needs for our families and look at resources, but to do the advocacy work to actually be able to affect social changes that will allow more and more of our patients and families to have access to these basic resources.
You know, it's a key issue. It's like that social policy change is what we need on so many of these issues. I wanted to pick up on this point about that we're seeing this discussion happening more and more now. And I wonder if part of that, though, is because of the work that's been done. So when I remember when I started to make this a focus of the work that I was doing back in about 2011 or so, that at that time, there was very little appetite or kind of discussion about tackling social determinants. Everyone had a sense that they existed, but they really were not, there was not anywhere near as much as there is now discussion about actually taking action and moving. And now we're seeing this in things like national guidelines, actual funding packages for health authorities and health providers. So is part of this, you know, are we having the discussion now in part because we've been talking about it, and like have we shifted the needle enough? I mean, it's not tackling the social policy, and I want to come back to the kind of screen and intervene as an issue. But what do you think about that? Maybe going back to you, Kate, has a lot of the discussion and early work, as limited as it is in terms of, because it's focusing on individuals one by one and it's not changing these big policies, has it maybe created a bit of a foundation for that?
I don't know that the conversation was limited to individuals one by one, because throughout that time I was working in policy and public health circles where these were, these had been part of the conversation for a long time. So I can't really comment on how it came from healthcare folks, but I do think that the experience of COVID, even though the door seems to have closed behind us quite quickly, did change the experience for people. That people started to recognize and understand that different people and population groups had really different experiences and risk levels. At the same time that the George Floyd murder and protests and Black Lives Matter movement happened, people started to think about their own accountability, maybe for the first time. Also to experience for themselves things like social disconnection, risk, and so on. So I think it's as much the experience as the conversations that went before. And this is why, for me, especially as a geographer, this work is necessarily multi-scalar, and the scales are in constant dialogue with one another. So, particularly for me during that COVID time, I was not only working for representing the community health centers who were trying their best to take care of people facing significant discrimination, marginalization, and health risk. But I was also a member of the Board of Health here in Toronto, trying to make decisions that centered those folks. And the only way to do that was in dialogue with those community leaders who were the experts. Though if we separated those two levels and the board were trying to make decisions, that board was not particularly representative of our city population. It's better now. I've stepped down. They have a better board now. But it was because I was able to talk to leaders working in clinics, working at that community scale. So it's that dialogue between the two. The best innovations and ideas and huge knowledge, expertise, capacity are in clinics, in centers, in community organizations. and they need to have the power to influence what's happening at that policy level. And they continue to be excluded from networks of power, and to me that's the issue. And some of these approaches help to bring them in by translating their experience into words and evidence that decision makers understand and respect. And it's a shame that we're doing it that way, but it is important. When we were able to take the narratives of risk into quantifying the risk for Black populations in Toronto, for Latin populations in Toronto, for example, then we saw action, right? Even though the people already knew and had been saying so. So we have a lot of work to do, but the discourse and the groundwork that was laid helped us to be able to take that action and bridge some important gaps during that time.
Yeah, thanks, Kate. And really, I think the pandemic has shone a lot, along with the social movements that have been calling for tackling systemic racism. And also what I think we're seeing now, which is a really big backlash against the growing cost of living and things like housing in so many of our communities. It's generating a lot of focus on how inequity is getting worse and worse over time. I wanted to just take a moment to just talk about some of the common challenges and critiques that come up, and then get people's thoughts on it. There's often concerns around the language that we use when we talk about bringing interventions into health spaces that are about tackling social determinants. So we use terms like prescribing as part of social prescribing. We talk about things like diagnosing social issues, whether it's food insecurity, housing insecurity, poverty. There's using, kind of as part of that diagnosis, there's using tools which exist for tracking purposes and also for actually remitting funds to health centers, which are often tied to diagnostic codes. So they're using diagnostic codes that exist for poverty, food insecurity, housing insecurity. It's kind of using those tools to, help centers get paid for this type of work. But is there a problem with using and actually kind of going down that route of diagnosing these types of things? There's also concerns about the screening process, and that we're screening for these social issues and trying to, I think one part of that is that we're categorizing social issues, which are very complex, into these small boxes that exist. But we do that, again, often because it fits with our medical centers approach. Our medical centers are overworked. There's a need to do things very efficiently, very quickly, a survey where we can screen and then say, yes, you need help, and then work to do that. Kind of fits with our model. But just yesterday I was having a conversation with a colleague who talked about spending the difference between taking like an hour to do an interview with someone, really understanding who they are, their context and the nuances, and then comparing it to a survey, and often what the differences between that. I think also part of the whole concern around screening and intervening is, does this take us away from the human aspect of healthcare? And that often part of what allows people to share with us what's going on with them is that relationship, the trust that gets established over time. So these are some of the concerns outside of, I think, the bigger picture, which is just, is this effective, and do we ultimately need kind of social policy change? But maybe I'll go to Arvin. Do you want to start? Kind of, you've written about these kind of concerns about this approach. Anything you would add to that, or any kind of thoughts about those concerns?
Yeah, no, thanks, Andrew. And 100% agree with everything Kate said. Like, these conversations haven't gone on for generations outside of the healthcare system, and we've been late to the party, and we're trying to join the party and vote. But at least in America, when we join the party as physicians in the healthcare systems, we want to lead the party and host the party, even though we know the least amount about this. So, the work that we've done, our research work, I kind of, in retrospect, wish I didn't use the word screening in the work we publish, because I think screening gives a different entity to what we're trying to do. When we instead of having conversations, we're trying to understand patients' perspectives, patients' needs. When you say screen in the medical terminology, the verbiage, it goes down a different pathway. I'd say a few things, because this is one of my pet peeves about this topic, is that our first assumption as a healthcare system is that our patients and families, they know the needs they have. They know if they don't have enough food for their family. They know if their housing is not sufficient. And they have been trying to get help. We have to assume our family's been trying to get help in navigating this the best they can. We don't have to diagnose a problem. So for screening, when we have the medical system terminology, why do we screen for medical conditions, right? We're trying to find something pre-diagnosis before the symptoms begin of a cancer or of high blood pressure or diabetes. We screen for something that's undiagnosed to make the diagnosis, to get management for those issues. When we talk about screening for social risks or social needs or social determinants of health or health-related social needs, whatever terminology you want to use, a lot of the tools that are being implemented in the US are using that medical algorithm where we're trying to screen for symptoms to make a diagnosis. So we're trying to screen for food insecurity, make a diagnosis of food insecurity, and then tell patients and families, oh, you are food insecure, I need to help you. That's not a patient-centered view. That's not centering the patient's voice in all of this. It is applying our medical dogma to these social needs and social issues. The way I see it is we have an opportunity to build trust with our patients and families by showing empathy, by showing caring, by showing that we want to help them if they want help, to partner with them to help these needs, because we know they're intrinsically linked to the health of themselves and for their families and their communities. And our role is to support them on their journey, which is very challenging, but not to try to tell them that they have a problem, that they need to get this referral. And that's kind of how I've gotten a little fearful about the way things have kind of gone down the pike in the US, where now there's all these policies in the wake of the pandemic and in the wake of the killing of and the murder of George Floyd, where health policies are now saying we need to screen for health-related social needs at every adult hospitalization. Many states are reporting to do this at least once a year in an outpatient setting, including in Massachusetts as part of our Medicaid program, which is the insurance for our poorest parts of our segment of our population. And so in America, again, our physicians, the healthcare system, we look very different than our populations who have the most needs, right? And so there's already this hierarchy that's already built. And we have generations of our patients who are Black and Brown who face this mistrust, who haven't been listened to the healthcare system. And if we screen for symptoms and try to make diagnoses for these really sensitive topics and needs for families who many of them already have a mistrust with the system, and rightfully so, given the harm we've done generationally and not listening to these marginalized populations, then what are we really doing here, right? And we're actually going to cause more harm than help. And so it's a really complicated issue. I think our intentions are good to try to be helping families and patients and try to partner. But I think, unfortunately, at least in the States, we've been applying our medical lens to a non-medical issue that is much more complicated than giving a prescription or giving a medication or having them come back in 3 months.
That's really helpful, Arvin. Two things that I wanted to just add on before going to Rithika for your thoughts, particularly in your current role as a lead around social justice and anti-oppression and advocacy. How does that actually how do we see that work happening, and how's it linked to this? I guess two things. One is that you mentioned that just at the end, the medical lens that we bring. Something I think a lot about, and actually it relates to our last speaker series, which was on education, is how does that lens change over time? Kate mentioned a couple of times that people have been doing this type of work for millennia, that there is a long history of people thinking and understanding social factors, community factors, and communities mobilizing to do things that improve their health. We use the term social determinants now, but there's a long chain. And what I often think of is, how is this medical lens going to change over the next 20 years? And how is that going to evolve to move maybe away from a really strong focus on biological interventions to something that's more broad? And are we, maybe many people have commented, like, we're starting to see more and more evidence that the traditional ways that we have approached health have been really shaped by other forces, whether it's the pharmaceutical industry or others, and maybe we're starting to move in a different direction. So that's kind of something that will be interesting. Can the medical lens change and evolve over time to adopt something different? And then the other thing that I wanted to just think about is how does the community mobilization, how does that work, and how do we get to that point from the system we have now? You know, how does this system we have now, which has a lot of challenges and issues, how do we move to a system that's more community oriented? Kate, mentioned, is coming from a long background working in community health centers, and the organization in Ontario that supports community health centers called the Alliance for Healthier Communities. And there's this really great model of that. But for much of the rest of the health system, it's not like that. We have many systems that are not community oriented, are not very good at that. How could this work, be part of it in a way of mobilizing communities? Ritika, do you want any thoughts on this? Because I know so much of your work is thinking about community mobilization.
Yeah, a lot of what I'm thinking about, and also relating to some of the questions in the chat, is that I think we've ended up where we have because, first of all, for those of us in healthcare as clinicians, I think we see, first of all, that the stakes are so high, right? We see the ways in which individuals and communities, I think, do face a lot of violence at the hands of the healthcare system. We see the ways in which we hold such incredible power in healthcare, but particularly as physicians. And that can also, feel often like a space where if we can direct some of that energy towards, more social purposes, that would be incredibly powerful or useful, that there is this whole infrastructure that already exists and tends to largely ignore social issues. So how can we sort of work to shift that a little bit, while recognizing that by definition, that's going to mean that you're going to engage in frameworks that are not necessarily, liberatory social justice frameworks, and tend to be a little bit more kind of medical in their nature. So I think what happens is that because physicians and healthcare hold so much power, we end up having to dress these interventions in language that's familiar to the people that hold power, because otherwise they would not engage with them. And I think I understand that, and certainly have been part of doing that, and have seen how it can be effective. But I also would say this is where our goal should always be clear, that these are not these are sort of temporary steps along the way, and these should be tools for building critical consciousness. And if we're not building critical consciousness through this kind of work, then what we're saying is that, we think social prescribing is the answer, which I know, Kate, is not what you're saying, or that, Arvin, you think that screening for social issues is the answer. And I don't think that's what you're saying either. But also that sometimes I think these concepts can get taken up and kind of run and have a life of their own, because there are certain ways of framing concepts that are much more attractive to medicine and healthcare, particularly, I think, pre-2020, where there wasn't that much of this kind of external accountability from social movements. A great example of this would be having spoken and presented about anti-oppressive practice in medicine for many years. I would not uncommonly be told that this is a very negative term, and why would we kind of take this approach, and we should use different terminology. And part of it, I think, is also that people in medicine are not really familiar with social sciences. They're not really familiar with critical theory, and so we often stay in the realm of what is familiar. And like Arvin said, we like to run the party and host the party, even if we're last to the party. And that has to do with our power. So I think for those of us that are thinking critically, it is even more incumbent on us to be raising those critiques like we're doing today, and doing that with our colleagues so that we don't lose the plot when we're doing this work.
That's really, really fantastic. And it really makes me think of how often do we say this is a step towards something else. That I do think, and I would say I've been guilty of this myself, is more presenting, here's the solution, here's what we're doing, but not necessarily saying this is where we're trying to get to. This is because of the system that we're in, that we're adopting this type of approach, we're using these tools, but where we really want to get to is this. I wanted to bring up, just as we're concluding kind of our conversation, we're going to actually move to questions from our audience. Is some examples of this, of what we've seen, where we have actually hospitals, both in Canada and the US, actually realizing that people experiencing homelessness are the root cause is their experience of homelessness, that they are homeless, actually moving to build housing, to actually become authorities of housing. And this is quite a dramatic, I think, move for folks, but financially it makes sense for some of these health systems. It's cheaper, far cheaper, for them to actually provide housing to people and make sure that they're secure within it, than for them to be continually coming to the emergency department, being admitted to hospital, incredibly expensive, and then being discharged back to the street and repeating this. But is there a problem with that? Does this let government off the hook? Or another example that's been coming up is actually food security, actually providing in settings that deliver healthcare traditionally, actually giving people food or food vouchers or things like that. It can be really powerful for people, but where does this maybe be a problem versus where is it more seeing health spaces, particularly primary care spaces, as an amazing place to integrate many different services for people? Kate, what's been your thinking about this? Is there possible to draw a line, or is it still very fluid? What do you think?
Well, I think there are a couple of things. First, that despite the name, social prescribing is really rooted in self-determination by people and by communities, and that's really at the heart of health promotion. Something that we've known for a really long time. So that means people have autonomy to make their own decisions, and that they're supported to do that. So a prescription really comes from oneself in dialogue with the people that are there to support us and help us understand what's out there. What can we do? Where do we need help? Where can we offer help? It comes from competence, remembering and being celebrated for what we can do, and being reminded that we are put in positions of discrimination where we're not able to enact our work to our full potential. So what can we do to expand that? It's rooted in relatedness, a real feeling of belonging in community, and sometimes having food together helps us feel a sense of belonging. Having a safe place to be and live together improves our sense of belonging, security, and rootedness, right? And then the last one is our ability to give back, our beneficence. And when we see people who are able to be a volunteer or even just support someone else with a welcoming smile, we feel really good. So those components of self-determination for individual people and communities really do need to be at the heart of it, no matter what the intervention looks like. When it comes to whether this lets governments off the hook, from my perspective, the healthcare system is part of the work of government. So if it's one arm of government or another, which is not to say that, it's a partisan activity, but it's funded primarily by government. It's in the social interest to offer a healthcare system. What that healthcare system looks like could and should evolve over time as we learn. But our healthcare system still looks the way that it did at the time of Confederation, when individual entrepreneurial, like black bag holding doctors were seen as the primary agents of giving medicine to other people. And, many indigenous and women-oriented, feminist, midwife, you name it, we're carved out. And then reinforced at the time of Medicare, right? When the doctor strikes and so on, reinforce some of those paradigms. We do need to evolve and change. And if that means recognizing social determinants of health have huge impacts on our health services, our health outcomes, our health experiences, then why not embrace that and tear down some of the silos between government ministries that are really causing unnecessary division between they silo our thinking about what's considered a health issue and what's something that's in the purview of government. To me, those aren't meaningful distinctions. They're inheritances of colonialism, and that impacts us all.
In terms of this idea, I think we're coming to, which is around like we're trying to see things transition. And Kate, many of the things you mentioned, I agree with. I think a lot of these things that we're talking about are actually helping. They may be called a certain thing, but they're actually moving us in a certain direction. It's tricky sometimes to see that. I really like the earlier point about like let's be clear about that. Let's do that. It's I think also a really pragmatic view towards policy change. How does policy change happen in a complex system? It doesn't happen with individuals like just saying this is the right thing to do. It happens through these types of movements. I want to maybe a final question to everybody here, and I'll go around to each of you, starting with Arvin, then Ritika, then Kate, and then we'll move to any Q&As that people pose. But if social determinants are really at their heart about social justice, are there downsides for this happening in health settings? Are there possibilities though that open up with engaging the health system? But if our goal is actually social justice, what's the pros and cons of being rooted in health systems? Arvin, do you want to start?
Yeah, it's a great question, Andrew, and I'd say yes. Just to go back for a quick second about the housing building for health systems. I think in the US, every nonprofit hospital needs to spend some money on the community. So it's not always from altruism that we're doing it. There's a pot of money that the healthcare systems are using. And we think about the housing itself, they're doing a small part of it. They can't scale it up for all the patients who need housing that serve it. So I'm a little cynical about that. I think that's part of what we can do. Hopefully from that experience, we can learn, leaders can learn the importance of it, and we can advocate for public policies. Going back to your final question, Andrew, healthcare, at least in the US, I thought I can speak of, the health system has been the wrong side of history for generations. We've opposed universal healthcare during the civil rights movement. None of the medical organizations stood up for civil rights. So this is a different journey for us that we're now trying to incorporate the social determinants in the care that we're providing. And hopefully that will allow us to be better proponents, better advocates, and using our vaulted voice, as Ritika said, in medicine, to be able to advocate for social policies. Look, the evidence suggests, unequivocally, that if you invest in social policies, you have better health for your populations. International studies show this. In the US, states show that. And so just like we try to provide effective medicine, evidence-based medicine to our patients and treatment strategies, there is evidence-based social policies out there that we know promote health. So why shouldn't health systems, using our vaulted voices, advocate for that apolitically, but going for that based on the evidence? And so yes, we can be part of the social justice movement by using our voice. Again, we can't be the host of the party, we can be partners of it, but we can use our vaulted voice in society to be great advocates and partners on this.
That's great. I'm going to actually move to Ritika and Kate to see if we could answer some of the questions for your response to. Just picking up on Arvin, your point of one of the first questions is about how do we build that allyship, with community-led movements, and how does that actually happen? Maybe Ritika, do you want to start with that? And because many groups outside of medicine want to invite progressive health professionals to be part, but how does that happen?
Yeah, I have lots of thoughts on all of this, and I'm looking at all the questions, and I think we have seen a pretty significant shift in the past 10 years, thinking of medicine as an institution and the ability to do kind of more advocacy from a social justice perspective. There's more space for that, and I think there's more, interest in that. At the same time, someone who is educating on this, it is an ongoing issue that the ways in which we educate around advocacy often further this very individual sort of sole leader type of model of advocacy, and that's really problematic because that's not what social movements are about, and certainly I don't think physicians should be leading any social movements. At the same time, I think we need to be politicizing everyone, right? And so the healthcare system and physicians are part of the general population that I think have it's probably additional responsibility to be speaking out publicly. So I think there's a lot of kind of complexity in the details of how to do that well. And so I come back to this thing of critical consciousness, because I think that's actually the answer. Because if you just teach people the nuts and bolts of speaking out and advocacy without actually teaching them about oppression and power and an analysis to understand, particularly as physicians, in the role that we play in the social class that we sit in, and how often that can actually be in contravention to the needs of the public. If we don't have that analysis, then I think that's where things go awry. But I think I guess I also feel hopeful because there are so many people that I think are thinking about this and are trying to do it and are trying to build that power in a way that's thoughtful and community-led.
That's really good. Kate, the next question I think would be really great for you is, how do you create spaces within health settings? And you've seen such a gamut of different settings, from community health centers to big hospitals to boards of health. How do you create those spaces that allow for these discussions about issues like oppression and harm? Actually, how does that happen?
So, I mean, maybe I can describe it in a concrete way in terms of how we're doing it at the Canadian Institute for Social Prescribing. So, one of the main things we're doing is providing resources for that to happen. We're naming it as a priority. We are paying participants to be at the table. So big organizations, we spent the last year working only with community organizations, less so with health ones. So we have United Way and some of the bigger pan-Canadian health organizations, but also very small organizations representing communities that face specific barriers to health and health equity. The big ones are providing their services in kind. The small one, we pay to be at the table. And we have participants, community members, also paid to be at the table. And we all, have created structures, and processes around our table to make sure that the people are supported, not just financially, but in lots of other ways to fully participate. I think it means making the space for the real, I shouldn't say the real expertise, but some of the expertise that's been excluded, deliberately excluded from health conversations, social determinants conversations. And there is tons and tons of expertise at that community scale. And so bringing that in, ensuring that boards are more diverse, for example, and putting our money where our mouths are to make sure that that really happens, that's an important step. And so then we can sort of unleash the capacity that's already there. There are many important ways of knowing, types of knowledge, ways of doing that are happening in community, but in an ad hoc way, maybe, that we need to really systematize, and we need to take that systematization seriously. And I think we do have the capacity to do that if we make it and name it as a priority and are accountable for it, and are very transparent, and we measure our success, and we listen to feedback when we inevitably make mistakes and learn along the way.
Thanks so much, Kate. I think that's really practical advice too. I really like that. And I think we're starting to cover kind of what can happen within at the kind of smaller level with providers and their education. What can happen at organizations in terms of leadership, and what can happen at a higher level, like a community level, around policy change. I'm going to give each of you a chance, just any final thoughts. And part of it is, is this kind of final question that's a bit overarching, is how can we actually address root causes while still coping with the demands of the healthcare system that is there. It has to exist to meet patients' needs. People are getting sick, people are getting injured, there's a need for care. And how do we still do that, but still think and actually move towards addressing root causes? I'll maybe start with Arvin and then go to Ritika and then Kate, but any kind of final thoughts?
Yeah, first, thank you for hosting this again, Andrew. And it's been a great hour. The time just flew by for me, which is always a good thing. I don't have many final parting words, but I would just say that that I've learned a lot from this conversation, and the healthcare systems don't have the answers. The only things we can do is to better understand our patients' needs, where they come from, their strengths, to create partnerships, to create empathy, to create trust, to create support, and create meaningful conversations that can better inform the care we provide moving forward. And we need to partner with our policymakers, our public health advocates who've been doing this for generations, to help out any way we can to try to enact more equitable, fair social policies.
Thanks so much, Arvin. And really strong, focus on listening and empathy, and really returning to that as we do this work. Ritika.
Thanks again for this. I think for each of us to constantly be pushing ourselves to think about what it is that we can do within the spaces that we're in. As healthcare providers, we often have access to so many spaces and so many places of power that communities may not have access to. And so thinking about what is incumbent on us and what is our responsibility to be said in those spaces, and also where can we push the conversation, where can we push it in our own workplaces? How can we push the conversation from being one about, very clinically oriented interventions to thinking about anti-oppression and thinking about social justice more broadly? And the more that we normalize those conversations and normalize that kind of work, I think that's how the bigger picture culture change happens. And we all have to be a part of it.
Thanks so much, Ritika. And Kate, final thoughts.
First, I want to thank each of you. I'm so heartened to know that there are physicians who are taking such a heartfelt and critical, but also empathetic and thoughtful approach to what you're doing. And so for those of us here today who are not clinicians, I think my advice would be to lean on our physician allies when we can. They do have power, they do have access, and it's okay to use that power in the service of opening doors and breaking down barriers for the rest of us and for others. And likewise, I hold power in policy spaces, and it's incumbent on me to use that in a way that broadens our inclusion. So I'm just really, I'm inspired and I'm energized, and I know there are challenges, and I know that there are some real opportunities too. And I'll just say the last thing I want to say is that the evidence was really clear that the communities that fared well during COVID, despite significant challenges, were those that had strong local community infrastructure. And could help take care of one another in times when they couldn't necessarily rely on big institutions. And so that's one of the reasons I'm so invested in really building that architecture locally, providing supports and resources for people who know what to do but need the money and the sustainability, emotional sustainability, as well as economic and environmental sustainability to do it. And we're facing some big changes. There's a rise in fascism and climate change and all kinds of serious concerns that are oftentimes well beyond the purview of what happens in the physician's office. But if the physician's office is part of a strong, resilient local infrastructure whereby we can help take care of one another, we can weather change together.
That's an amazing, point to end on, Kate. And I really think that's an amazing vision of us also, weathering the future storms that we know are going to, beset us as well. I just want to end by thanking everybody. I really I really appreciate all of your time. Thank you, Arvin, Rith, and Kate. Really great discussion. I know this is going to really inform my own work and my own thinking. And thanks to everybody who joined us, really engaged. Thanks for all the comments and questions that people had. I hope everybody can join us for future sessions. I know we're going to be tackling some big issues in the future, including the climate crisis, including things like how do we build social infrastructure to and be part of those types of solutions. So thank you, and I hope everybody has a good rest of your day. Take care.